For the latest in strategic affairs, subscribe to our YouTube channel. Click the bell icon for updates.
Hello and welcome to StratNewsGlobal and welcome to this special show on Omicron. I hope I've got the pronunciation right. Is a new coronavirus variant that's appeared in South Africa and appears to be spreading rapidly, perhaps even more than the Delta variant that we have dealt with so far. So what is Omicron all about? I have with me Professor Srinath Reddy of the Public Health Foundation of India. You've seen him on our screens before. He is an authority and well spoken of in terms of these pandemics and epidemics and generally on public health. So welcome, good to have you.
Namaste, pleasure being with you.
So what do we know or not know about Omicron, the new variant of the coronavirus?
Well, we know that it is a variant that has emerged in recent days. It was first recognized in South Africa, though it's not clear whether that is where it actually originated. But since South Africa is an excellent genomic surveillance system, they managed to detect it very quickly. But we also know that it is spreading very rapidly in the province of Gauteng in South Africa. So it appears that at least in the terms of the actual threat it poses, it is in South Africa where it's been recognized first, and even the clinical features are being recognized fairly clearly. This particular virus has many more mutations than the Delta virus, which is the most dominant virus now globally. In fact, it has 32 more mutations on the spike protein. The spike protein is the one which the virus uses to open the doorway to the human cells. It attaches itself to the ACE2 receptor on the cells, then prizes open the entry into the cell, and there it uses the human genetic material for replicating itself. So the more mutations the spike protein has, it is assumed that it has far greater ability to penetrate into the human cells and then infect people and also reproduce itself in large numbers. The fact that this virus is capable of infecting much more is also now being borne out by the rapidity with which it is spreading in at least the Gauteng province of South Africa, and it has now carried over to several other countries as well. But at the moment, it appears it's not as virulent as the Delta virus because so far no deaths have been reported and only relatively mild symptoms are being reported. But we still have to wait and see because unless we have many more persons to study, we'll not be able to come to a definitive conclusion.
Now,
but
so you mentioned
worry is about potential for immune escape because most of the vaccines which are currently being used in the world are directed at the spike protein, and if this spike protein mutation complex can actually evade the immunity, that will cause a bit of a problem.
So you mentioned that it mutates more than the Delta variant. So the fact that it mutates more, does that make it more dangerous?
Well, it has mutated more. It has acquired many more mutations. Dangerous in terms of infectivity, yes. Dangerous in terms of virulence, we do not know. So far, there is no such indication. In terms of immune escape, yes, there is a potential because most of the vaccines that are currently available have been directed against the spike protein, except, for example, the Covaxin that we have, which is an inactivated virus vaccine, which has many more antigens of the virus, and therefore it is not limited only to the spike protein. But the mRNA vaccines, as well as the virus vector vaccines that have been mostly used all over the world, are directed only at the spike protein. So if the virus develops many spike protein mutations, the assumption is that our immunity, which has been produced by the vaccines, may not be effective in capturing and controlling and quelling the virus. Whereas people who have been infected by the actual virus, because they've been exposed to all the antigens of the virus, perhaps their immunity may be much better against this particular variant because it's a much more broadband immunity.
So you're saying that those who have had the COVID infection and recovered, obviously, they are in a better position to fight this virus?
Theoretically, yes, because there are two ways of how the immunity acts. Firstly, immunity acts by way of antibodies, which try and capture the virus before it enters the cells. And they hold the virus captive till the killer cells come and kill the virus in the bloodstream. The other component of immunity is after the virus enters the cells. And then other cells take over and then try and kill the virus while it is in the cells by killing the cells which are containing the virus, the killer T lymphocytes. Now, if the spike protein has developed multiple mutations which make it difficult for the antibodies to recognize the virus, then the virus can actually escape capture in the bloodstream and can more easily enter the cells and then create the problems. But if the T cells or the T lymphocytes are still active and the cellular immunity is there, then the virus can still be overcome by fighting the battle not in the blood but within the cells. But people who have been exposed to the infection would have a much broader range of antibodies against many of the viral antigens, whereas people who have been only given the spike protein laden vaccine are more likely to have strong immunity against the spike protein, but not as much immunity against the other antigens of the virus. So there is going to be a differential advantage there.
So would you say now that the new variant could be the biggest danger currently to after the Delta variant, or that's still to be determined?
Yes, danger interpreted now. WHO also has put out a big warning. Yes, it is likely to be more infectious. Yes, it is possible that it may have greater immune escape ability that we'll have to test. It's still being tested. But is it going to be more dangerous in terms of severity of disease? Right now, there is no such indication. Whatever early indications are there is that it actually produces milder disease. It appears to have traded off increased infectivity for reduced virulence. That is the early indication, but we still need more studies to confirm that. If that happens, it means that it's a process of evolutionary biology where the virus, which is now being limited by vaccines and masks and many other instruments that we are using to control its spread, is trying to break loose by increasing its infectivity, but at the same time, it is reducing its virulence because when you have a virus which wants to sustain itself, it cannot afford to kill the limited number of people whom it infects. If you have a huge number of people whom you can infect, who do not put up a resistance by way of their immunity or do not put up a resistance by way of masks, then the virus need not reduce its virulence. But on the other hand, when it meets people who are offering resistance to infection, it will increase its infectivity but reduce its virulence. So that may be what is happening to this virus at the moment, but we still need more studies to confirm that. So in terms of severe infection and death, right now there is no indication it's more dangerous or even as dangerous as Delta. Possibly it could be less dangerous. We'll have to wait and see. More infectious than Delta, likely, based on its current configuration. More likely to have immune evasion effect by way of, at least from the vaccines, more likely. But that also doesn't mean that the vaccines are totally useless. There will be some degree of immunity conferred by the vaccines, which may still be protective against severe disease and death, though mild infection may still be possible. So we'll have to wait and study those effects.
So how are we placed to deal with this? One case has been detected in Bangalore. I'm sure other cases are coming up. Are we better placed today to fight this new variant?
Well, Firstly, we'll have to look at prevention and then look at detection and treatment. For prevention, I think the best way of preventing any virus, including any new variant, from entering our body is to not offer it a portal of entry. If we can protect our nose and mouth with masks, and preferably protect our eyes also with some sort of eye protection spectacles or face shield, then the likelihood of the virus gaining entry into our body is greatly reduced. Secondly, we should avoid large crowds, and particularly in ill ventilated areas where the virus can actually hang around as aerosols and spread from person to person through viral clouds. We know that aerosols play a role even if people are not standing next to each other, even if people are in two adjacent rooms, the aerosols can spread the virus as virus clouds. So we have to make sure that we are having ventilation, we are having masks, and then we are also vaccinated so that in case we do get infected, we do not suffer severe disease. And then if we have symptoms, we should get promptly tested. So that is the way to go about it. But in terms of prevention, masks and avoiding crowded events and staying in ventilated areas is the best prescription. In terms of treatment, there is no particular difference in the treatment that is going to be offered because the virus is the virus. It's only the question of whether it can enter your cells more easily or whether it can evade your vaccines more effectively. That is the difference. So as far as the virus itself is concerned, the steroids will help, as has been shown in the clinical trials. Some of the antiviral agents may help, as has been shown in some clinical trials, and they're also being tried out even now further. So our strategy for management of the infection will remain the same. If indeed it is shown that the symptoms are much milder than that of Delta, then in a sense we are getting a lucky break because then most of the people can be treated at home. You don't have to worry about too many people getting into the hospital or intensive care. But even there, elderly persons, people who are immunocompromised or immunodeficient and have associated health conditions which make the virus more likely to create severe disease, like diabetes or heart disease, they should still take care. But compared to Delta, at the moment, we are not hearing stories of very severe illness. But it's too early days yet. We'll have to watch how the virus behaves over a period of time. Right now, it is the infectivity that one is concerned about. One is concerned about reduced vaccine efficacy. But in terms of severity of disease, at least the early indications are a little more reassuring than when Delta appeared.
See, a little while ago, you mentioned that South Africa has an excellent gene detection system or mechanism. How are we placed in that respect?
Well, South Africa actually refined it very well because of its HIV/AIDS and also because of tuberculosis. And they really refined it very, very well. It's one of the best systems in the world. And that's why they managed to catch it very early. The British, in revealing to the world about the Alpha variant, took 2 months. These people just took a few days.
Yeah.
We did not really build up our genomic surveillance network as strongly till early January. It was only when Britain said that the Alpha variant had come in, and we were worried that the Alpha variant might have traveled from Britain to India, particularly to the Punjab and Delhi and Haryana region where a lot of people were coming in from Britain. Then we activated what's called the INSCOG, a consortium of laboratories capable of doing genomic testing. That grew in number, in terms of number of institutions. But again, in January, February, when it was felt wrongly that India is going to escape the second wave, that false notions went around that we had all acquired herd immunity and therefore there was no problem at all. The kind of funding and organizational leadership that was required for push the INSCOG agenda was not there. I mean, the scientists were quite active. They were quite committed. But the kind of support that was required for funding these institutions and really building up their capacity was not there because it was wrongly felt that there was no further danger. But now, not only the government laboratories and the research laboratories in the universities, but also private laboratories, the consortium has grown. And they are doing a lot more work. Of course, it will take quite a while before we can reach the level of South Africa. But at least now we are much more active in that area.
So, last word. What is it that you would tell the public, viewers who are watching this show, this interview with you? What advice would you give them? How would you counsel them?
I would say be alert, be careful, but don't be alarmed or panicky, because we have had the worst possible threat with the second
Yeah.
wave of Delta, where we left ourselves unguarded completely, and we bore the brunt of a terrible second wave. Now we are in a better shape. We have had some immunity from the natural infection, some immunity from the vaccination, and if the accounts from South Africa are right, this virus is not likely to result in as severe disease as Delta. So we are not going to be as badly off as when we were in March, April, and May this year because of Delta. However, do not take chances. Wear masks definitely when you're outside the house. Keep your house well ventilated to the extent possible. Move around also in public in well ventilated areas, and avoid crowds as much as possible. So these are important elements. And if you have unusual symptoms, because now South Africa is reporting that the symptoms are not typical, it's
Yeah.
mostly muscle aches, headache, feeling of severe weakness or lassitude, some degree of stomach upset or churning, nausea, not the classical dry cough and breathlessness that was there with the virus so far. If you're having any unusual symptoms or fever, whether they're classical symptoms of Delta or whether they're unusual symptoms, definitely get yourself tested. And if it so happens that you're having mild symptoms, definitely isolate yourself at home, get tested, and make sure that you get the supportive care. But if you have any more serious complications, then certainly you should get hospitalized. But the important thing is to be on alert rather than panic.
And this can affect even those who are vaccinated, the double vaccination
Yes.
also.
Firstly, it is being stated that the reinfection rates are higher because, as I said, immune escape phenomenon may be more. Because, as I said, if the antibodies are mainly directed against the spike protein, unfortunately, most of the vaccines that have been used in the world are spike protein specific vaccines. In fact, Catherine Wu from United States, wrote that we are having a monogamous relationship with the spike protein. And whereas the inactivated virus vaccine has more antigens to target. So it is likely that the efficacy of the vaccines may be reduced, and therefore people may get reinfected. And secondly, we also know that these vaccines have a waning immunity after 6 to 8 months. So people who might have been vaccinated early, like health workers who were vaccinated early in 2021, may have reduced immunity and greater susceptibility now.
And would you, there's a lot of buzz about a booster dose and all that. We are not yet in the stage of recommending that, or
Pardon me, I didn't
there's
catch
a
that.
lot of buzz about the booster dose, of the
About the
vaccine.
booster dose. Well, as far as the booster dose is concerned, I think basically some of the countries have overdone it. Some of the countries, unfortunately, do not have access to the vaccines to give boosters even to the people who need it. I believe that some of the Western countries and other vaccine rich countries who have been vaccinating everybody about 12 years of age with booster doses, Israel started it, USA is following it, and Europe is also now taking it up. They have overdone it because they have actually cornered the supplies and utilized them when many other parts of the world needed it, particularly vulnerable sections of the people, the elderly, as well as the immunocompromised people, and even healthcare workers were not even getting the first dose, not even the second dose. Certainly, Many of them did not even get the first dose. And to give third dose to everybody about 12 years of age was not the correct practice. Yes, boosters will be required for people who are more likely to get severe disease. They are the elderly people above 65 years of age, people with conditions like diabetes, pre-existing heart disease, and other conditions which increase the risk of severe disease, as well as people who are immunocompromised at any age. Even children aged 10 years who are immunocompromised need protection. But to say that everybody above 10 years of age or everybody above 12 years of age is going to get 3 doses of vaccines when people on the other side, part of the world are still waiting for their first dose of vaccine is actually inviting disaster for themselves, because it's not only being unfair to the rest of the world, but you're allowing variants to be born and bred in other parts of the world in under vaccinated populations, and they'll come back. One day they'll surely come back and travel to your country, and they will infect you. And then again,
Yeah.
you will go for more boosters, and you'll start tweaking your mRNA vaccines. It's like a dog chasing its own tail. So you have to be much more uh, understanding of the global needs, and it is both, altruism as well as enlightened self-interest in order to make sure that the vaccine supplies are spread across the world so that everybody is covered, rather than only few people being saturated with vaccines and others being starved of vaccines.
So, last question, sir. How soon do you think we'll know whether this new variant is going to be worse than Delta or less so? How soon do you think?
We'll know in about 2 to 3 weeks' time, because if more people are getting infected, then if
Yeah.
infectivity is really as high as is being reported or being
Yeah.
thought of, then many people will get infected. So we'll have an opportunity to look at the clinical outcomes, both in terms of how many people are getting severe disease to get into the hospital, and then we'll start seeing how many people are getting long COVID. All of that, long COVID we'll know only in about 6 to 8 weeks. But in terms of initial impact, I think we'll know in 2 to 3 weeks.
Dr. Srinath Reddy, thank you so much, sir. Great insight and good value public information. Thank you very much.
Thank you. Bye.
And for all of you out there who are watching this program, keep coming to us with your comments, observations, and questions. Subscribe to our website. Thank you. Good night.